Thank you. It's a real privilege for me to be here today and to be invited to join this three-nation approach to reducing harm from falls. I'd also like to, in the terms of how we work in Australia now around acknowledgement to the Aboriginal people, I'd just like to give acknowledgement to the Māori and their elders past and present and those here today, and to acknowledge the land on which we are as Māori land. It's probably not of your custom necessarily, but I'm so impressed as to how this week it's Māori Language Week, and listening on the television how much the language has been incorporated now into your culture. We've got a long way to go in Australia. I'd also like to acknowledge the work in the past of some very impressive people from New Zealand. Professor John Campbell, who has since passed away, Claire Robertson, in the work that she's done with Otago. I've met Claire a number of times, and Leslie Gillespie, the work that she's been doing and still, I think, is involved with the Cochrane Reviews. Very impressive people who've been very formative in my early times in the work that we've done, and I especially enjoyed their company in Dunedin when we had the Australian New Zealand Falls Prevention Society conference there a few years ago. I'm not going to talk rugby. That's all I'm going to say, being an Australian. Happy to mention the cricket, because there is a Ashes series in Sydney coming up at the end of the year, and I am married to a cricket tragic, so we will be at the Sydney Test after New Year. Just want to locate us, New South Wales. I am from New South Wales. We're talking about the work we do in New South Wales. Previously, we had a national jurisdictional group around falls. We shared a lot of information. Sandy might have been part of that at that time across, and that was when a jurisdictional committee that used to report through to the ACT, the Australian Medical Health Council. However, since then it's sort of fallen off the agenda. We don't have quite that same level of cohesiveness and collegiality in terms of collaboration readily. But we're more than happy to share our experiences and learn from one another. So New South Wales has a large population, nothing like the population of our colleagues from the UK in terms of the area, but our area is 3 times the size of the United Kingdom. So tyranny of distance can be a challenge, and I know that would be the same for you here in New Zealand as well. Just like to show a picture, welcome to Sydney for our UK people when they're coming. And down in the bottom there you'll see the big banana and a beach scene. I actually live in Coffs Harbour, which is between Sydney and Brisbane, and the big banana is a great feature, and I'm waving to you from the big banana. And I'd also like to say that the suburb I live in is called Karora. So somehow, I don't know what the New Zealand influence potentially was there, something for us to look up at some point. The New South Wales public health system is world class, we like to say, and it is the largest public health system in Australia, and you can see there some of the data. We've got 213 hospitals that we're influencing in the work we're doing, and a large number of multi-purpose services, which are long-stay residential aged care, as well as small acute responsive service as well. I just want to highlight, because ambulance has been talked about, that in 2015-16 calls for ambulance were high, with roughly around 8,131 per month for falls. Now, a large number of those are not transported, what we call non-transports, and so we're working with our colleagues in ambulance now to look at some of the work that they could do around that. We've had different projects at different times, and some research work that Professor Jackie Close has been doing in regards to responding to people who've fallen and working with ambulances. I actually haven't put a slide in about all of that work, unfortunately, but happy to provide further information. While I am talking about ambulance, because I perhaps won't come back to it, is that we do have a rather active paramedic now, and we've tried different things. We've trained them using screening tools, we've trained them using Quick Screen, which is one that's been developed at Neuroscience Research Australia, initially for rural nurses. It's a long tool, it's a very good tool, comes in a box, it's a kit, but now we're using another screening tool, and she's actually been quite ambitious about getting all paramedics to be screening for falls when they go in, and people who are on the floor particularly, or talking to them about falls and fall history. So we've got more work to do in that arena. New South Wales is a picture there. That's our local health districts. We've got 15 of them and a couple of networks, a Child's Health Network, St Vincent's Health Network and Justice Health as well. So we work across the 16 with the St Vincent's Health Network, local health districts. And each of those local health districts I have working with me for what we would call a falls coordinator, but unfortunately they might be doing 2 days a week or 3 days a week and working on other big programs as well. So it's a very, very fine spread for a very big program of work that we're trying to do. Just talk about some of our data about fall-related hospitalisations. It's been mentioned before. The numbers of people coming to our hospitals increasing. The red line at the top is female, the blue line is male, and they're over 65. What else is interesting is the fact that our fall-related injury hospitalisations are also increasing. And within that data, hip fractures are actually decreasing on hospitalisation. That's a trend that's happening worldwide, and no one's really clear to my mind at this point as to why that is the case. But we know of the injury that's coming to hospital for us in New South Wales, and the ED trauma people were quite surprised by this when they came and spoke to me. We knew it, but it is older people with falls that's the highest trauma and injury, more than road accidents, and that surprises a lot of the trauma people working in ED. We have significant work that we still need to drive in that interface of people coming to hospital for falls and fall-related injury. The injuries that we are seeing on the increase are head injuries and other fractures, particularly sort of pelvis and upper arm fractures. So we're needing to watch that space. Now, the work that's been done in New Zealand is really impressive, and I thank Sandy and Carmela for the opportunity for me to hear more about what you're doing. I did ask our biostatistician. I might say it's only just recently I've got access to a biostatistician who could help me with some data. I'm absolutely delighted. Plus the fact that we're actually building a system that can actually look at some of our data. Now, it's by hospital separations. I would have preferred this to be by occupied bed days because that's how we usually do and record our data, but we're in the process of changing. That top blue line is total falls. The red line that you can see is our fractured neck of femur. The greeny coloured, olive coloured green line is intracranial injury. So, and this data we are pulling now from our hospital acquired complications list set by the Australian Commission on Safety and Quality in Healthcare. And we did try to pull this data with the same coding that New Zealand had used for theirs. We think there's probably a little bit more refinement to do in that discussion, but we now have coding for hospital-acquired complications. And we have actually building a system which will now be launched on the 22nd of September, whereby each hospital will have access. We're calling it QIDS, the Quality Information System. Each LHD will be able to go in and have access to look at their hospital-acquired complication data, plus their IMS data, which is our incident reporting system. Further work to be done, and we've only done it from July, September 2015, because in New South Wales we weren't particularly good at flagging condition onset and all those other issues in terms of reporting requirements. We have a little bit more work to do around coding. If we look at our incidents in hospital, first on the your left-hand side is our SAC1 and SAC2 serious incidents. SAC1 would mostly be death, SAC2 is serious incidents. Smallish numbers, but significant for us to be concerned. The other half of it is the SAC3s and 4s. Debatable about falls. We get lots of questions about falls and around what does it mean and the definitions of falls, and we've taken it as a standard when a person ends on the floor by the World Health Organisation, and in discussion with our falls experts, that is regarded as a fall. So if they've had to be lowered and assist to the floor, there's something that's happened here. We need to ask questions, what's happening with this particular person on that day. And most of our falls are happening, I didn't put the slide in our older population, so 76 plus. in our data, when we look at our incident information management system, it's those people who are falling. But interestingly, looking at the times when they're falling, and it's around those peak times, mostly during the day, and we know that there's a lot of activity happening. So the questions we're asking now is, sometimes it's around what the medications are, what staffing is available. Obviously, they're probably getting up and going to the bathroom. And when we review our serious incidents, mostly it's around they fall at the bedside or mobilising in the bathroom. So we've got big questions to ask around, well, what significant things do we need to drive improvements in those areas? I just thought I'd put this latest release of the Australian-New Zealand Health Fracture Report. This is the annual report and the key findings here, led by Professor Jackie Close and Ian Harris, Professor Harris, in collecting. It's a New Zealand collaboration with Australia. And I think probably one of the things that I'm quite pleased about is, you can't see it clearly, but you can at Google for the report, is that 95% of hip fracture patients have unrestricted weight bearing immediately after hip fracture surgery. I think that's a really good statistic because we need to get people up and mobilising, and that's some of the work we're doing. We've still got lots more work to drive, and talked about the orthogeriatric model in terms of working collaboratively with our specialist geriatricians, where we have them. We don't have them uniformly across New South Wales, unfortunately. I want to talk to Don Berwick as well, and we've had that excellent presentation. So he was talking about from the patient's perspective. These are the things that patients really want when they come into our care. Don't kill me, don't harm me, and don't do things that cannot help me. I think that's very challenging. So some of the work I see when I review our serious incidents, we've got large numbers of people with comorbidities who are very sick. They get transferred from our residential aged care to our care. Sometimes they have to be transferred because of the fact they've got a fracture, it needs to be attended to. Sometimes they've got complex health issues. And when they come into our care, we investigate them and we do everything to them. And I sort of query it by saying, why do we torture the older person in terms of the things that we do to them? Medicine's made some, this is personal view, medicine's made some marvellous changes, and we've got great standards of things that we can do now, and we've got shorter timeframes in which we can now deliver care. One of the things that has enabled, though, is that we can investigate. Until we investigate, we will find something that's wrong. So it gets to a point as to at what point do we continue to actively treat, and what point do we actually manage that person at their end of life. Now, I haven't put the slide in about end-of-life care, but we actually have at the CEC a toolkit just recently produced around end-of-life care and helping to make decisions about when do we actively continue to treat or not. And sometimes I actually don't think these people need to be in our acute care environments. We need much more caring, palliative type environments where we can keep them safe and look after them with care and attention and acknowledge that stage in the phase of their life. The other thing is don't waste money. So sometimes I think we keep repeating things that don't work, and we probably are wasting money. The Clinical Excellence Commission that I work for, this is some of the work that we do. It's responsible about practice improvement, clinical care, safety and quality across the New South Wales health system. And these are some of the building blocks of programs around safety and quality that we have in place and are continuing to develop as well. Care of the older person in hospital and the work that we're doing is around what are the quality markers for good care. And they're around falls, cognition, continence, pressure care, medications, nutrition specifically. And we need to look at integrated approaches and how we're going to provide caring environments, particularly around some of the design issues. And we feel that some of the facilitators for success is the whole of hospital, whole of engagement, not only at our ward level, but we actually need our boards engaged. We need executive endorsement and supporting to build and support capability. And more particularly, we need to be focusing more on engagement with patients, families and carers. And I know here you've done some excellent work with Anne-Marie Hill recently from Western Australia, and I'm envious, in fact. We'll have to get it to Sydney. And I tried actually for our forum in September. around the work that she's done that's really impressive about how we have those conversations with older people in our care. I put this in, Professor Stephen Lord did this and we've adapted it slightly, about risk factors for falls. My further adaptation is the canary. And I think someone's already mentioned this. I like this slide because falls is complex. And why people falling, there are lots of issues around why people are falling. And I think it's like the fall is like the canary. It's the alert to something is not quite right with that person. And that's the inquiry that we need as to what's happening here, what's not right, what are the things that we need to be thinking about. And there's a lot of challenges clinically for us to be thinking about what's happening. And unfortunately, sometimes the tick boxes that we are using in terms of our tools stop us really thinking a little bit more broadly about what might be happening in the context of the care of that particular person. So some of the drivers that we've had is the first, what we called the green box, hence we developed green. We do have pockets of some of our LHDs that decided they were going to use orange, but the work we do is branded with green. And then we've gone on to the 2009 guidelines, evidence-based guidelines. Now, there's still good information in those. And Professor Lord has provided an update, and that's with our Australian Commission right now, as to whether or not when that will be published. But we also have, in terms of the evidence, and it was mentioned, the Cochrane reviews. And Professor Ian Cameron has completed it. It's now out for review. I actually have seen it. There's not a lot more evidence to inform us about what we should be doing in hospitals. The other thing that's driving our care also, and has from the Australian Commission, is our quality and national safety and quality health service standards. Standard 10 is around preventing falls and harm from falls in hospital, but also applies to how we work within our community health settings as well. Now, this has been quite good to help us put systems in place and standardise some systems. But what has actually happened, and the question I keep asking, is we've become so compliance monitoring and so a lot of work to produce work to say that we can get accreditation. But in the inquiry and the practice improvement and the sustainability, we've still got a lot more work to go in terms of just meeting standards. So my question is now to our people that we're working with, what are the contemporary skills that we need now in a changing profile of care to deliver safe care? And some of the work that we've been driven from our Ministry of Health now is around leading better value care. So we've been asked and tasked with looking at refocusing on falls in hospital. So to do that, we want to look at what's reliable and what are sustained interventions. Now, none of this is new. It's all being talked about today in various ways, but we are going to be refocusing on how we skill our staff to improve some of the care that they're providing. When I've reviewed most of the serious incidences that we have, apart from them happening in the bedside or in the bathroom, there might be environmental issues there, is mostly a lot of it's around cognitive impairment and staff not understanding cognitive impairment, and particularly not picking up where people may have a delirium. The other part of it is around safe mobilisation, and we haven't done, as other jurisdictions have done, significant work around safe mobilisation. I'll show you some of the resources that we're developing. Medication review and reconciliation and reduction of the use of night sedation is ongoing, and access to pharmacists can be a real challenge for us in many of our settings, particularly when we get into our rurals. Intentional rounding and linked with that with a toileting plan. We've had some significant, excellent work that's been done in one of our local health districts around this particular area. And we will be showcasing this in Leading Better Value Care, and they've done some very nice videos around how to do intentional rounding significantly. We know when it's done well that we actually reduce serious incidents. And it's a mind shift with staff as to how we go about and those conversations they have with people around when they go into their room to look at to ask about their personal care needs particularly. We do need to improve on our multidisciplinary team collaboration, including our engagement with our medical staff. And we've talked about huddles and teams and clinical handover, and I'll touch on that in a moment as well. So these are just some of the strategies, if you like, but we want to build it in a way that it becomes more meaningful, and I guess that's probably more of our challenge that we have ahead. Now, we do still risk screen. I know it's a no-no, and everybody said no. I had a conversation with Frances 5 years ago, and Frances says, don't throw out your screening tool yet until Anna's finished her research trial. Well, I was on the steering group with Anna in that work that she did, and we had a different tool. Now, the reason we argued for it at the time, we still have it, it's time for it possibly to go, is we found that our staff didn't really understand falls or what were the things that led to people being at risk of falling. So the things in the screening tool that we're using, which is a modified Ontario Stratify, and please don't get hung up on tools, because I don't get hung up on the tool. It's there, is around the things that we want people to be thinking about mental status. Are they cognitively confused? Has a cognition screen been done? Has a delirium screen been done? And what interventions, if there's a delirium, what pathway of care are you on? Is there have they a history of falls? Is there syncope? Postural hypotension? These are the important medical questions that need to be sorted as well. Are there problems with vision? Are there problems with mobility? Do they have problems with toileting, and do we need assistance in regards to that? And at the bottom we talk about medication and medication review, and the culprit medications for us are the antidepressants, antipsychotics, benzodiazepines and opioids. This paper base has been now translated into our EMR, and we've got various versions of EMR, so it's not an easy process for us to unify it. And I think from what I'm hearing here in New Zealand, you've been much more effective. In our admission tool now that comes in, we've actually done it as integrated comprehensive tool, so that questions might be asked, but they wouldn't know that they're answering a screening tool by any way. So that it's been integrated, and it will prompt for specific tools such as a CAM at this stage, or a CAM for a confusion assessment method for delirium. And some of our geriatricians now are using another tool called 4AT as well. So we've got further work to build in yet another tool into the EMR as well. But really it is about how we prompt our staff to be thinking about the things we need to be thinking about when we've got someone that's older in our care. What are the things that we need to care about? And one of the things that I think is really important that we've lost in this transition from technical care, improving technical care, and it's a conversation I had at length with Anna Barker in her six-pack trial, was the fundamentals of care. So we've got staff who are really well trained. The IVs and the BIPs and the monitors and everything else, they've been driven in their practice to deliver and manage those. But how do we actually deliver good, safe care around toileting needs and identifying how we actually assist and support someone to be mobilising and be with them and supervising them in those care needs that they require. Fundamentals of good care. And we've slipped in that. And some of the work when Anna was doing the focus groups, some of the new graduates or staff were saying, but toileting is not what I'm about. So we really need to think about our care and our workforce now. Because if our registered nurse staff don't see that's part of their duty or job, then whose is it? And how do we skill our staff to be able to see that that's a really significant part of our care? It really is significant in terms of the fundamentals of delivering safe care. So I just wanted to put this slide in about older people coming to hospital with dementia. So we do know that they come, but often they come with a fall-related injury, and they have a dementia and a confusion. They could have a delirium over top of a dementia. But quite often we can have people who come into hospital who are confused. It's never been formally diagnosed. And they'll get a diagnosis of dementia, and that may stay with them the rest of the time, but it's never been investigated. And it's never been clearly identified that they've dementia and putting on appropriate management and pathway. So significant issues in this whole area. So we've been working with one of our other agencies, the Agency for Clinical Innovation, who actually has developed care of the confused hospitalised older person, CHOPS. And if you Google care of the confused hospitalised old person, you will come up with this suite of resources that's been developed there. So we're working closely with them in regards to understanding cognitive screening and delirium in particular. Some of the work that we've done to support raising the awareness is through the programs and promotion that we do through April Falls each month. And I know now in New Zealand and other places throughout the world have picked up on this work that we developed up in New South Wales. And we did one on confusion, and these are some of the flyers and promotional material we did. One of the significant things I think is we talk about heart health, and we'll talk about our vital signs for heart health, but we don't talk about brain health. And we've heard today about coronary units, and you look at a coronary unit, how many staff do they have in a coronary unit to look after someone with a heart problem? How many people do we have for an older person with a brain attack or there's problems going on with their brain? We often put them in the room isolated way down the bottom of the corridor, and we'll be lucky if we can get one-on-one staff even when they require it. I think that's a significant challenge for us around us, how we support the care of a person who's confused. Equally is a vital sign as it is for coronary heart, where all of the money and accolade has gone. A lot more work for us to do in this area. And I'm picking up on some work that Francis showed some years ago, but we did go around with a photographer looking at the environmental issues as well, which has a large part of the problem work we're doing. It's confusing. It's very different from home. The clutter, the environment, the high sheen on the floors that sometimes people will go to avoid because they think it's a pool of water. And where on earth will they not find in these pictures, actual pictures recently in the last few years, as to where the bathroom or toilet is? Some of them you wouldn't know. Some of them think the toilet is in the middle of that brown chair there. There's no adequate signage at all. And how you place appropriate signage with visual images as well is significantly important. And also, some of the work that Francis highlighted, and we went around and took photos as well, is how confusing it is when they've got to reach and fumble around equipment to get to press the button in terms of flushing the toilet and so on. We set people up to fail in the environments in which we care for them. And we need to be mindful of that as to why some of our incidents might be happening. And we can't really assess that. If you've got an older person with a walking frame and or IV stand, and they're getting up, which happened with me with my mother after a mild stroke in hospital, and she said to me, well, what do I do now? She had the IV stand, she's stable on her feet, and she's trying to work around how she's going to get back to press the button at the back. So I don't know if we leave people on their own in the bathroom with all that equipment. Is it the equipment? Have they gone? Have they fallen over the prod of the IV stand? Lots of work for good engineers to help us get much more appropriate equipment to help us. Post-fall, if we do have a fall, we've actually developed a guide, and most people would be aware of the sorts of things to be doing. We needed to develop a guide. And we've picked it up in the terms of clinical response and rapid response, which is between the flags, one of our other programs about patient deterioration. And so we'd actually be asking to people to be on the alert and to continue to monitor people might have a delirium. If they're on head injury, it's interesting. I've seen in serious incidents where the staff will be writing, confused, pleasantly confused, increasing agitation, MET call, rapid response. Suddenly they've going to God very quickly. Now, we may or may not have done anything neurologically in terms of investigating. We might have done a CT scan. CT scan, first off, may not even give you show you that there might be a slow bleed. But we've got, as particularly patients on anticoagulants now, we need to be highly vigilant. And there'll be decisions then about what kind of treatment would be appropriate following a fall. But it's really significant for us to be mindful of that. And what we're introducing now, and I haven't given the visuals of this, is around post-fall huddles. So post-fall huddles is when actually we'll get a team together who will actually go and talk to the patient after a fall and say, if they can, or the families and carers, and say, what happened here? What went wrong? We're sorry this happened in our care. What could we do that would be different? Let's plan a plan of care together. So we've got some great work that's being done where people are beginning to model that. And once that begins to happen, we've found our falls rates are beginning to reduce. The rest of the staff get the notion. And it amazed me because often I see serious incidents and big long RCAs, and I'm looking forward to talking to Francis a little bit more about this, where people have gone and done these fabulous long investigations, spent ages on it, and no one spoke to the patient or families and carers. They're our great prime source of information. Some discussion today about safety huddles, and that's somewhere where we're working through as well, around preemptive care, so understanding at any one point in time those people who are at risk in our ward at any one time. And on this other side here is some prompting questions that we're beginning to develop up around those people at risk of falls and highlighting those. So on a ward at any one time, how many have I got that might be at high risk? Have they a delirium? Have we got a mobilising plan in place? Is there a toileting plan as starters in regards to that? And we've got lots of information and flyers and resources that we've developed, as everybody else has as well. And as I said, we've got some focus now around mobilising and introduction to mobility resources. So we've done some work around, for our community people, I guess, is around how to do balance and strength, introduction to balance and strength, tests, not exercises so much, we'll move into that shortly, and the safe use of mobilising equipment as well. And these are available on our CEC website. Thanks to, with adaptation from the Auckland District Health Board with permission, we have redone our work around mobility and the levels of assistance. And we've actually standardised the terminology. I didn't put that here. One of our health services worked with their allied health staff and physios and discovered that there wasn't any uniformity in understanding what we meant by some of these terms when we talk about them. So actually we've got a standardised terminology guide now, and then this suite of resources to support it. Other work, borrowing some work from South Australia that we're adapting as well, is Give It a Go. And that's in around trying to get people up and mobilising rather than languishing in bed. Our physios have been telling us, and I'm sure this is the same elsewhere, that we often have people staying in bed and they're waiting for the physio to come and do the mobility assessment. Well, actually, the evidence is the sooner we can get people up safely mobilising, the better outcome we have. Reduced short length of stay, particularly, is one outcome. And you all know that if you keep people in bed for too long, you lose muscle strength and poorer balance. And we don't want to decondition people any more than they already are because of their acute illness. So we're looking at how we can support staff to have some decisions about when they can get people up and safely mobilising as well. I talked about leading better value care, and we will be evaluating this process over time. So we actually will be looking for improved patient and staff experience and outcomes, and it's around efficiency and effectiveness of care. We do have a KPI. I think it's a fairly mild one, really, so a lot of us will meet it. A lot of them will meet significantly within 12 months, only a 5% reduction in hospital falls, leading to intracranial injury, fractured neck of femur and other fractures. Now that's the Australian Commission on Safety and Quality Care hospital-acquired complication data set. And with that data, this next 12 months, they are looking at not incentivising, if I could say that. So we're actually looking at a model whereby the payments to health services may be limited in regards to their NWAs or their payments if we actually end up with a hospital fall. Now that I think is really tricky. That's really harsh. And we know that Sharon Inouye, who's done a lot of the work around delirium and falls, has written extensively on this as well. And for those of you who might be interested, Sharon Inouye is coming to Sydney in October. I think it's the 23rd of October. It's listed here, and is running a delirium masterclass. And so if anyone's interested, we'd be happy to give you that link in Sydney. Now, this is just our timetable around some of this work we're now doing in terms of leading better value care. We're doing it, we are following the IHI model fairly extensively in New South Wales now, and we are doing it as what we call a small C collaborative. So we'll be bringing hospital teams in and we'll be talking to them about the process of change that we're looking for and equipping them with further quality improvement techniques and strategies that they'll be able to use. Now, significantly in this work, it's not how our leaders do it, we need their support. It's how we influence our frontline staff. And it's been mentioned today, they often know what the issues are. So how do we engage our frontline staff to be leaders themselves in looking at the practice and how they can refine some of the things that they're doing as well, and how we can work together on that. And I just want to highlight that we've done some work with mental health, and that was a workshop that we ran in August, and we've got further work, and some of those teams will be involved with us in this Leading Better Value Care. For those of you who are interested in our quality and safety improvement capability, we do have what we call a QI Academy. It's very simple, it's got some very good tools there. If you're interested in understanding those tools, I do suggest you go and have a look at that. So what have we been doing about care of the person in the community? So that's a big body of work that's been driven now again back in hospitals. We have done some work in community, and particularly with our community health services. And this is the area of work where I think we've got bigger bang for our dollar if we can invest more into this. And that's the work that I personally would find more interesting and challenging, really how we drive primary and secondary care settings. And I know that's where Sandy's moving to. So we're really wanting people to be identified at risk or doing our preventative strategies as well. We have got yet another tool, a screening tool, that we've picked up, and that's from our working group that we did. It's a FROPCOM, it's 3 questions. And mostly we've done this again because many of our health teams really weren't necessarily alert to asking questions about falls or understanding where the person might be at risk of falls. And decision trees about what they could do. So if it's low level, what do we do at a low level? What information could we give them? How do we support them into balance and strength exercise classes? Or at high level, where are the teams that can do a much more focused multifactorial intervention, and how would that happen as well? So that's further work we're building on. And we actually have developed a procedure for following a fall for our community staff if they go in, as to the things that they should be looking for and the inquiry that they should be asking. And we've got lots of brochures around, flyers for patients and families and carers as well. So on our website you'll see different resources that we've developed as one-pages that may be helpful to help guide that conversation in your conversations with older people. Some of the other work that was done in one of our health services, which I haven't seen much about, is equipment installation and safe use guidelines. A whole stack of them that we've got on our particular website as well. So if particular pieces of equipment are being used to go home, you could use this as well as a guide for the person. So we've talked about engaging with patients, families and carers, integral team members. And we actually, once we've got everything else right, we actually do need, they are the next level of how we improve the care that we deliver, how we engage with them. And when we refocus our care around engaging with patients and carers, we actually do improve clinical outcomes. We actually have, through our Top 5 program, which is asking 5 key things, particularly for a person who's got dementia, confused. What are the 5 things that we need to know about this person from a carer? Because carers know. That would help us in delivering good care. And we write that down on a little guided piece of paper, which is then talked about at clinical handover. And clinical handover is really important, essentially, to get those sorts of bits of information about that particular person. And we've actually demonstrated a reduction in falls significantly when we're improving our communication, staff to staff and staff with patients and families and carers. Now, you've all probably seen this. This is an excellent resource that we use quite extensively, particularly when we start talking about understanding confusion. It was developed at St Guy's and St Thomas's, Barbara's Story. It's a series of 6 video vignettes. And if you haven't seen it, I do urge you to go online and on YouTube to have a look at it and use it. We use it a lot. We've also got some patient stories as well. And other resources. The first one is Suzanne Archer. I met her in the art gallery at Coffs Harbour, and she'd had a fall, fractured a pelvis, And what she had done is an installation about what that meant in her journey. And it was in a cabinet, all these little figures explaining what her story was like in hospital. It was fascinating. So we got her and talked to her about that. So I do urge you to have a look at that from a patient's experience. So some of the other, just briefly, and it's been mentioned, we developed an active and healthy website. When we first did this, it's around locating programs for falls prevention that were building a balance and strength component. We had Professor Stephen Lord and Professor Kathy Sherrington helping, and Anne Tieneman with us on this, developing just some guidelines about how we would engage engage program providers. And now with this particular one, the contract for this has now gone to the George Institute under Kathy Sherrington, and we're broadening it to increase other physical activity options, bearing in mind that we need to increase physical activity. So there'll be other program options available. So we're promoting active communities, and this booklet's been around for a while. We also have done statewide investment to build capacity around stepping on. And we've also developed it in 12 different languages, where it's been run, of course, in some of our larger multicultural local health districts as well. And we've had some lovely rural volunteer programs that have been done in our rural areas, where we've actually trained and support volunteer coordinators who've been trained to run the Paul Lamb Tai Chi program and also a community exercise program around strength and balance. And we've trained in one local health district. I think we've got about 170 volunteers. Now, this works in small communities where you don't have access necessarily to other programs. And we're finding from there the benefits are it's the social cohesion, the social interaction, and they meet for coffee now and they talk. Socially, it's really put a lot of people who might have been isolated. And we also have a Get Healthy coaching line now for people who want to think about losing weight or getting healthy. It's a New South Wales Health. This was a project that worked with Trish Nove and Kitty Kerr from one of our health districts. And someone asked about engaging with community service providers. This work is around working with community service providers, and they called it the Healthy Older People Partnership Project, and it's around keeping people fit and strong. And this was their partnership structure around how they went about it, so some of you might be interested in this and following up. But what was significant in terms of this work is they actually worked with care workers. They're not responsible for teaching exercise. They're responsible for prompting, but they've been given more knowledge about falls and what the risk factors might be. Beyond just moving mats, they're sort of a bit more aware, and someone might be a little bit more at risk or wobbly. Now, we've got people anecdotally, and we're just about to go into research work with one of our universities to really look at this more meaningfully. But anecdotally, some of the stories have been remarkable, whereby patients or people, in their own homes, through a care worker prompting them to do simple-based, Otago-based exercises, where their strength and balance has improved dramatically, and their health outcomes. And some of the work following that is flash mobs. This was last year. This year we did one in Blacktown. In fact, the police in Bankstown, police were so impressed with this community initiative, they want us to run one up once a month. We haven't done a lot of work in residential aged care because we're not responsible for it, but we've got a lot of residential aged care people who are working with us in that regard. And some of our research partnerships that we're partnering with that you might be interested in is the work of Professor Lindy Clemson, iSolve, that's working with GPs and how that we can engage them. And also with Dr. Kim Delbare, who's actually doing some very innovative work on standing tall exercise, delivering exercise to people in their homes for those people that don't want to go out on iPads, and they love it. We're getting good results there as well. The Falls Prevention Network you might well be mindful of. So our take-home message, or mine really, is that we all have a role to play in keeping people safe. We are looking for clinical improvement and how we can provide this care and work together. And we must acknowledge the excellent work that's already been undertaken. Thank you.